Without ado, we shall go on to the different typical case presentations, and which should cover the entire gamut of glaucoma. And we have with us Dr. MAYURI KHAMAR, who is the glaucoma consultant at Okra Eye Care and Research Center, Ahmedabad, with a 30-year-odd experience in glaucoma and has held very important posts in prestigious groups like the All Gujarat Ophthalmic Society as a vice president. And she is going to tell us about her very interesting case, a patient with end-stage advanced open-angle glaucoma. On to you, Dr. MAYURI. Would you share your screen?
Yes. Is it visible?
Yeah.
Yeah. Full screen.
Okay. In the next 6 minutes, I will try to cover 2 cases of mine, how we treated, which are advanced case of open angle. We all have seen such advanced cases with the 0.9 CDR, pale disc, and the very small tubular island. And we think that this is not, it's a hopeless thing, but it is not so. You can see from these 2 fields that we can control or monitor glaucoma, and patient can have a good vision or useful vision all throughout their life. These are the patients who are at a high risk of progression and very low margin of the play is there. But the aim here is to how best we can improve the vision in these patients. It is also difficult to monitor this patient as the imaging fails because of the poor floor effect, and the visual fields cannot be used a routine field, but you can use the 10-degree program or the macula program. And if vision is too much less, then you can use the large size stimulus. And they need frequent monitoring. Visual field should be repeated 3 to 4 months, and it can have a high variability also. And these are the list of the risk factors for the progression in advanced glaucoma. And one has to carefully look at those factors and treat them vigorously. So can we preserve this field in all patients and that to lifetime? Yes, we can. There are so many studies in the literature which says that by reducing the intraocular pressure less than 13 millimeter of mercury or reducing 40% from the baseline, we can achieve to have a good success in the treatment. Also look at the IOP fluctuation, which is an independent risk factors. Now, how low one can go? And here also, if we go very low, then you can end up with the hypotonic maculopathy. So the therapeutic window of intraocular pressure is quite narrow. And these are the 3 modalities that we use. But for me, the filtering surgery, if the target is not achieved, could be a better option compared to the others. The medical line of treatment, monotherapy, difficult to achieve very low. PG analog and ROCK inhibitors, they can reduce the intraocular pressure less than episcleral venous pressure. But with the many combination therapy, now we can achieve the good control of the intraocular pressure. SLT can be of use. It reduces the intraocular pressure by 4 to 6 millimeter of mercury and also reduce the diurnal fluctuation. So patient who is not willing to take the risk of surgery, or you want to postpone surgery for some time, you can use this modality. The surgery trabeculectomy should be enhanced with the antimetabolites, and releasable suture is much, which gives you stable chamber on day 1. And the tubes, I think Ahmed glaucoma valve is a better option compared to the non-valve options. But the most important thing is frequent counseling of the patient and the relatives regarding the wipeout, or the one has to give injection mannitol preoperatively if the pressure is high, and paracentesis if pressure is still high, then you can do that. And anesthesia, preferably topical or peribulbar if you are giving, avoid the adrenaline and orbital compression. The antimetabolites should be applied over wire area and posteriorly. And the paracentesis gives you slow decompression and the also helpful in maintaining the antechamber all throughout. And the releasable suture is a must in all these patients, and always check the wound integrity at the end of the surgery. So how to monitor? It is very subjective assessment, And the patient response is most important indicator, and the drop in the visual acuity is a sign. Now let me share the case. 80-year male who was on treatment for glaucoma, stable since 8 years, and left eye was lost after the trauma. He was using dorzolamide, timolol, pilocarpine, and brimonidine. And these are the data. Vision improved to 624, left eye chysis bulbi, and you can see the corneal thickness was also good. This was the field done in 2017, which was similar to the previous fields and the OCT. So what we did, we revised the medication and we added the travoprost to the whatever he was using, and the combination therapy was suggested. After 1 week, the AT was 19 millimeter of mercury. So we discussed the possibility of anti-glaucoma surgery, but patient was not being one-eyed, not willing. After 2 years, due to COVID time, he could not come, and he came in the December this last year, and with a severe loss of vision since 3 months, unable to see the food in the plate. So everyone was tense, and the intraocular pressure was 45 with the vision only now 5 meters. And he was already on the oral treatment. So post-mannitol, the intraocular pressure reduced to 28 millimeter of mercury. And these are the perimetry reports, macula size 5 and 10-2 program, very, very less field. So marked progression, uncontrolled IOP with MMT, one-eyed patient, regular follow-up, not possible. So what to do? We suggested again the trap with a very high risk, and wipeout was explained. This time they were willing to undergo. We did the surgery.
1 minute remaining, ma'am.
Okay. Should I finish?
You have 1 minute left. You can finish.
So the vision was 4 meters unaided on day 1, and we were happy. Now the another patient, 90-year, very old man, gentleman, the daughter is a pathologist in USA. Known case of glaucoma since 20 years, had multiple allergies to the multiple drugs, was using 2 drugs, timolol and latanoprost, and systemic hyperlipidemia. So one eye vision was 636, and the other eye was only counting finger 1 foot temporal, and pseudophakic open angles with the glaucomatous optic atrophy in left eye and the similar change in the other eye. And these are the imaging and the visual fields of that patient. Now, this is the 10-2 program with size 5 stimulus. Target was not achieved and patient refuses surgery. We suggested SLT to this patient, and we did it, and the medication was continued, close monitoring was done, and still today, I am seeing this patient. The both eye feels stable, and he is happy, and we are also happy. So to conclude, these are the cases at high risk for going the blind, but one has to manage aggressively in these patients, and close monitoring is required for the patients with the risk factors. And incisional surgery offers the best chance of achieving despite some risk. However, one may choose medical or laser therapy in some of these patients. Thank you.
Thank you very much, Dr. Mayuri. I have a question for you, Dr. Shushmita. Would you consider that there is any role of a stage surgery in this end-stage glaucoma, especially if the cataract is not too significant? Would you like to knock it off at the same time, or would you be conservative?
So that would depend. So the usual, the usual thing that we say is that if there is a cataract, which if the patient needs glaucoma surgery and there is significant cataract, then they need to be out. And usually in end-stage disease, one would not like to go in again and again. So if there is a cataract, but a cataract, not a lens extraction. So if there is a significant cataract, yes, we might as well take it out along with the glaucoma surgery.
Dr. Shailesh?
Yeah, we often talk about wipeout phenomenon. I just know all those panelists in this country, how much they face this wipeout phenomenon in end stages. That is the one thing which we always tell the patients, wipeout. Is it really scary? And what are all the indicators which will, who are those high risk people who can go for wipeout?
So I think we've learned that low pressures intraoperatively as well as postoperatively is something that we really need to take care of. And nowadays, I think most of us use viscoelastic substances and a lot of tight suturing with releasable. And frankly, touch wood, the incidence of wipeout is really less, even though we work on one-eyed, very end-stage glaucomas. But it's important to, of course, tell the patient. And interestingly, in all these years, one or two that we've seen, with topical steroids and therapy, they actually do seem to reverse. So it's not such an irreversible thing as well. So interestingly, they did, but the incidence is very low. And I think
you
it's
should.
to do with.
I think you need to avoid hypotony at all costs.
Absolutely, at all
times.
costs, especially intraoperatively and post-op. No hypotony, then that's the usual thing.
Yeah.
Dr. I think the raised pressure also is not a good thing. Any spike in the immediate post-operative period.
Yes.
Shanta has a publication where she has done a prospectively the risk of wipeout. And as I don't remember the exact figures, and it's very low.
Very low, yeah.
Take care of the intraoperative hypotony and also post-operative hypotony and post-operative spike.
Why
and
is
also
it
maybe not operating on a very high pressure eye, use mannitol, see to it that the pressure is reasonable before we enter the eye. I think that also would be important.
Why is vision loss after TRAB supposed to be counted at 3 months on? Why is that so? That probably the early days when the patient's vision actually dropped down significantly in these very advanced eyes, and then over a period of time it builds up. What could be the explanation for that? It is probably the IOP building up?
Possible that the homeostasis gets back, because immediately post-TRAB we do see, and maybe there might be a little bit of macular edema or macular hypotony initially, and with inflammation and with steroids, when all that settles, possibly it comes back. But yes, they do come back with steroids.
One last question, Dr. Tanuj. Are there any tweaks which you would advise in a surgery, something different in these kind of end-stage glaucoma surgeries?
So I think very critical is the anesthesia. So if you can avoid giving large amount of course, retrobulbar should never be given, and avoid giving large amounts of peripulbar that increases in intraorbital pressure, and that can be deleterious to the optic nerve. And that is one of the causal factors for wipeout, not the surgery, but the anesthesia. The second issue is, of course, you operate only on a soft eye. And if there is preoperative, patients are, like Dr. Mayuri showed, on multiple medications, you should stop the medication, give the patient oral Diamox, and give a short period of steroids, maybe 1 week or 10 days, to reduce conjunctival inflammation. That will increase the success of surgery. And during surgery, of course, you can use some viscoelastic. Another option is to use an anterior chamber maintainer. That helps to maintain the AC during surgery, and it also washes off any hyphema or inflammatory mediators released at the time of surgery. And at the end of surgery, you should have a formed AC with releasable sutures, and you should not be in a hurry to take out the releasable in the early post-operative period, because if the eye goes into hypotony, then you will have loss of vision. So I think these are few points which are important for these patients. And mitomycin C should be used 0.4 milligram per ml posteriorly for 2-3 minutes, because you require a low target IOP. Thank you.
I think you've covered it all. Anything else to add, Dr. Nangia, Dr. Chandrima, before we go on to our next speaker?
I mean, I think that everyone has covered a lot of points. It's been very rare for me to have seen a wipeout, and really you end up operating on patients because there's no way out at that late stage. So we've talked of hypotony, and we've talked of elevated intraocular pressure post-operatively. And I think that's the fight that we have, the conflict we have with the eye, to make sure that it's not too low and not too high. So I think the use of mitomycin, being prepared to see the patient very frequently, use massage, use laser suture lysis, use needling as and when required. I think these are all critical to saving the sight in such an eye, actually.
Yes, thank you so much. And yes, Rashmi, we agree with your point too.